Hello, everyone, and welcome. I'm Shelley Gunther, Clinical Marketing Manager at Clarius. Thanks for joining us for today's live webinar, Precision in Pain Management, Ultrasound-Guided Therapies for Chronic Head and Neck Pain. You are among just over 2,600 clinicians who registered for this popular session today. And we're really excited to welcome back renowned pain management expert, Dr. David Rosenblum, for this session. In a moment, Dr. Rosenblum will show us how he uses high-resolution wireless ultrasound to educate us on the ultrasound of the cervical region and how to improve the accuracy and effectiveness of cervical spine injections for pain management. These procedures have historically been performed under fluoroscopy, but as you'll see, cervical spine injections can be performed safely and accurately using ultrasound as a guide. And you're going to get some knowledge and skills to expertly guide precise targeted delivery of steroid and or anesthetic. Now, just before we get started, a quick housekeeping note, please use the Q&A icon at the bottom of your screen at any time to ask questions, and we'll address those questions following the presentation and the live scanning session. Now, I have the pleasure of hosting today's webinar, and just before I introduce our guest, I'd like to share a couple of papers relevant to today's topic. This first one is a recent review of the literature, 75 articles in total, and it aims to comprehensively identify differences in the accuracy of intra-articular injections via palpation versus image guidance in the most commonly injected joints in the upper and lower extremities. And they concluded that the image-guided injections, particularly ultrasound-guided, were shown to be more accurate than palpation-guided injections for all joints. They also found that image guidance with ultrasound allows for navigation through soft tissues, distorted anatomy, and neurovascular structures, decreasing complication rates. Now, this next paper, the primary purpose of the study was to determine the accuracy of ultrasound-guided cervical facet joint injections using a lateral technique. And the secondary purpose was to describe the technique. And the authors concluded that the cervical facet joint injections can be formed with a high degree of accuracy using a lateral ultrasound-guided approach. And the final paper was a really good review of relevant anatomy for both Janae and me in preparing for this webinar and live demo. So it's for pain physicians in their quest for learning all about ultrasound-guided nerve blocks of the head and neck. And the authors cover several types of blocks and provide excellent descriptions and corresponding anatomical images. So I would invite you to have a look at that when you have some time. Now, just before we get started, I always like to know our audience a little bit better and kind of where you stand on ultrasound-guided injections. So what do you see as the risk and limitations of blind injections for chronic head and neck pain? Are you worried about being inaccurate? Are you repeating your exams, or are you worried about complications? Let's just give this another couple of seconds. 3, 2, 1. All right. So yeah, so it's kind of all about accuracy and avoiding complications, which totally it makes sense. Ultrasound is such a great tool for this. All right. Now I'd like to introduce our wonderful guest today. Dr. David Rosenblum is currently Director of Pain Medicine at Maimonides Medical Center in New York and treats outpatients at his various office locations. He is dual board certified in anesthesia and pain medicine. Dr. Rosenblum completed a fellowship in interventional pain medicine at New York University, where he also underwent 3 years of training in anesthesia. He completed an internship in internal medicine at Columbia's St. Luke's Roosevelt Hospital after having received his medical degree from Sackler School of Medicine at Tel Aviv University. Dr. Rosenblum has helped over 3,000 pain physicians become board certified as the founder of painexam.com. He's a huge advocate for using ultrasound to guide pain injections. He's a great teacher, and his patients love him. Dr. Rosenblum, I'll hand the mic over to you.
Thank you, Shelley, and I wanted to thank Clarius for the opportunity to teach. First of all, cervical spine procedures, I have a lot of passion about this because I do feel the epidurals with the X-ray guidance are done a little too quickly, and we can achieve the same goal without putting a needle so close to the spinal cord. So you'll learn here today a lot of that. So Shelley basically introduced me. The NRAP Academy, NRAP stands for Neuromodulation, Regional Anesthesia and Pain. That is my umbrella organization where the pain exam board prep podcast and all of my ultrasound courses are hosted. We do live and in-person training, as well as preceptorship and shadowing. You can scan the QR code for more information. These are my disclosures, and they should not affect much today. And we're going to just jump right into it with one of the part of it's less invasive procedures, which is the cervical plexus. And this plexus is formed from the anterior rami of C1 through C4. It emerges from the vertebral column between the longus capitis and middle scalene muscles deep to the internal jugular vein. So the plexus has a variety of superficial nerves. This is, I'd say, a lower level, simpler block to do if you're a beginner. Of course, anything in the neck could be hazardous, but this is pretty superficial. So I would start with something like this as opposed to a stellate ganglion block, of course, which is much deeper if you're not very experienced. Lesser occipital supraclavicular nerves, not the suprascapular, nor is it the supraclavicular brachial plexus. This is a nerve to the clavicle, okay? And the transverse cervical nerves. To go in depth, the lesser occipital nerve is a branch of C2. It innervates the area by the mastoid process posterior to the ear, basically lateral to the greater occipital nerve innervation. The greater auricular nerves, C2, C3, they go up, they emerge from the midpoint of the posterior border of the sternocleidomastoid and ascend towards the ear. The transverse cervical nerves, blocking these nerves that originate from C2 and C3, can be very helpful for post-operative neck pain or perioperative neck pain from an incision. It gets those superficial fascial plane in the skin. And then one of my favorites is the supraclavicular nerve at C3. Why is it one of my favorites? Because when a patient comes to the hospital or my office and they have a history of a clavicular fracture and the ortho doesn't operate, nobody knows what to do with these patients. Try a supraclavicular nerve block. They respond very well, and it's a very superficial, easy block to do. So you have the superficial cervical plexus block, which is the most superficial. The solution is really deposited between the subcutaneous tissue and the investing fascia. In the intermediate cervical plexus block, which is one we really don't talk too much about, the solution is deposited between the investing fascia and the prevertebral fascia. In the deep cervical plexus, the solution is deposited between the prevertebral fascia and the cervical transverse process. And we'll demonstrate here. Before we do that, the indications for the superficial intermediate are usually for perioperative pain, as I mentioned, superficial neck pain, clavicular pain. The deep cervical plexus block is classically used for the carotid endarterectomy. However, for the carotid endarterectomy, you could get away with a superficial cervical plexus block. It's still, in some cases, is adequate enough to do the block. So to perform the block, you want to identify the sternocleidomastoid muscle, which is this superficial muscle over here. And this muscle has a tail to it, like it just tapers backwards. And that area behind the muscle is where you're going to put your injectee. It's going to be usually about halfway between the mastoid and the clavicular head of the sternocleidomastoid muscle. It's a fascial plane block, basically. The deep cervical plexus block is by the posterior tubercle, usually at the level of C4. It also has the ansa cervicalis associated with this plexus, with the motor branches supplying the infrahyoid muscles. It's thought that deep cervical plexus blocks also has afferent components, and the cervical plexus has an anastomosis with the cervical nerves 10, 9, 12, and the sympathetic trunk. Caution, the C3, 4, 5 levels do give rise to the phrenic nerve, which if you block it, if it's unilateral, it may not be a big deal. Anesthesiologists do this all the time when we do interscalene blocks. You may need to use a benzodiazepine just for the anxiolysis in a patient who's awake. But if the patient has pulmonary issues, a contralateral phrenic nerve block, you're going to need to intubate, or you're going to have major problems with breathing because you don't want to have a bilateral phrenic nerve block. So it's inadvisable to do this bilaterally. Okay, so just scan here. You have the blood vessels here. the C4 nerve root, you see it's hypoechoic. There's more fluid content in the cervical nerve roots. In fact, a colleague once showed me an article, which I forgot to put the reference here, stating that there's actually some degree of CSF in these nerve roots, hence why maybe doing a selective nerve root block outside of the neck may actually alleviate the symptoms of a cervical radiculopathy coming from a central axial problem like a disc herniation or foraminal stenosis. Anyway, you always want to use Doppler. It's your friend, and you can help identify between nerves and blood vessels. Here's just a review of cervical anatomy, and I'd say the more important slide is this one. The shape of the bone, okay? You have the spinous process here, it's bifid. You have that curving lamina. You have the articular pillars on the side where the facet joints articulate. Then you have a posterior tubercle and an anterior tubercle. Above C6, you have the vertebral foramen where the vertebral artery is, and the nerve root and the medial branch. All this will be really important when we're looking with an ultrasound. So once again, the beam is scanning like this, okay? Almost like an axial cut, sort of. And you're getting the beam bouncing off the bone. So it's going to look something like this shape is what you get when it comes off the articular pillar, the posterior tubercle. And this is not bone, this is nerve. And it's hypoechoic because there's more fluid content. That's why it's black. These nerves get whiter as they go more distal. For instance, the infraclavicular brachial plexus will be whitish. It will not look black because it's more dense and less fluid filled. So the rootlets, they form from the dorsal and ventral spinal nerves, which emerge together through the foramen between the anterior and posterior tubercles, the epiradicular vein in the upper part of the intervertebral foramen. And the ventral ramus of C1 gives branches to the suprahyoid muscles. C1 through 4 form the cervical plexus. So something very important to note that a lot of us pain doctors, even myself, sometimes overlook. Axial neck pain, and it's not facetogenic, it could be radicular. A pinched C3, C4 nerve can manifest as axial neck pain. It looks like a facet or myofascial axial problem, but it could be actually a impingement of the exiting nerve root, hence radiculopathy. Therefore, you need to be mindful and sometimes do selective nerve root blocks for these problems or decompress. We talked about the phrenic nerve, and C5 through 8 form the brachial plexus, okay? And just of note here, in the United States, we are not reimbursed for doing selective nerve root blocks under ultrasound. It's a very sad thing because this is a safe, effective procedure. It's been proven. But the payer system here has just not caught up with the times. So what I've been doing, and I'm not going to advocate this because in case it's wrong, but I doubt it's wrong, you can build this as a brachial plexus block because if you look at any medical textbook, the roots of the nerve roots are part of the brachial plexus. Okay, so there's lots of ways to do this with selective nerve root blocks. You could go from posterior lateral to anterior medial and plane. You could I target the extraforaminal space. I am not sticking a needle into the foramen under ultrasound. I do not advise that. If you want to get more central spread, give a higher volume of saline, not local, because the saline could track inwards. To be honest, I usually don't need more than 1 to 2 mLs per level, and it works pretty well. I'd say 90% of the patients do well. If they don't, we can repeat it, use or do it with PRP, or you could do an epidural the traditional way with X-ray. Just on a personal note, I suffered from a cervical radiculopathy last year. I had the extraforaminal dexamethasone bupivacaine injection on my right side. It worked wonderfully. Did not help the left side. So at one of my ultrasound regenerative medicine courses, I had one of the students help me by doing a extraforaminal platelet-rich plasma injection. 4 weeks, neck pain was gone. 8 weeks, radicular arm pain was gone. So I'm a big believer in this, and I do think it's future. As you know, or hopefully do know if you're doing these procedures, all sorts of bad things can happen in the neck. So always put Doppler on. Make sure you're not in a blood vessel. Always visualize your needle tip. This is not a beginner shot. This is an advanced shot. You want in a beginner shot, do either the superficial cervical plexus or maybe a trigger point. You need to know how to find your needle because you cannot lose your needle this deep when there's nerve roots, vertebral arteries, carotids, all other sorts of hazards in the way, and you'll see that here. So scanning the neck, we're coming to the side, trachea to carotid, to thyroid carotid, finding the nerves line up. And what a trick is, you just tilt your probe upwards to find the interscalene brachial plexus. Us anesthesiologists use this all the time for shoulder surgery. And you can inject here with good relief for radicular pain or brachial neuritis. However, you could also scan these nerves towards the foramen, which I'm doing here, and you'll see it disappear. It's just a black circle that's becoming more amorphous because it's turning into the foramen. It's losing that circular shape. Now, you're going to see a lot of this today. We've have a lot of cases to present. It is repetitive, but remember, you're sticking a needle in someone's neck. The more of this you see, the better off you are. So here we go.
So we're going to scan Sarah's neck, and as I usually advocate, I look for the brachial plexus in the supraclavicular fossa. I find the subclavian artery and the nerves. Color mode. Okay, here's the subclavian artery, and the nerves are above it. I'm going to scan upwards into her neck. B mode. And the scalene muscles come into view. Anterior scalene on the right, and the middle scalene on the left. And the brachial plexus is between them. Following the nerves up to the foramen, you can see them disappear. They're black and hypoechoic. Scanning up her spine, I'm looking at the cervical foramen and the nerves going into the foramen. And above the level of C5, the posterior tubercle is larger than the anterior tubercle. So that's one way to distinguish between C4 and C3 versus C5 and C6. C6 is Chasternak's tubercle, which is a larger tubercle, the largest actually of the anterior tubercles. So once again, the posterior tubercle is larger above C5, and that's more or less how we know we're around the level of C4. Also, the carotid artery will bifurcate, as you see here, at the level of C4 or C3 in most patients. Also, we see the sternocleidomastoid, and at this point, we could do a deep cervical plexus block by landing the needle on the posterior tubercle and injecting, which is good for surgeries such as carotid endarterectomy. Or we can do a superficial cervical plexus block, which gets the transverse cervical nerves, which is good for post-surgical pain syndromes of the neck or cervicalgia of the neck, as well as the supraclavicular nerve, which is ideal for clavicle fractures, and the lesser occipital nerve. Now, in this location, I tried to demonstrate on the patients before. The accessory nerve is sometimes hard to find, but it basically runs from the jugular foramen out towards the sternocleidomastoid and then laterally towards the trapezius as we go down the neck. And here's the trapezius, this large muscle on top. Here we see the carotid, and at the level of C6 is Chasternak's tubercle, which is going to hopefully come into view in a second. Right there. The large anterior tubercle of C6. The target for the stellate ganglion would be behind the carotid artery on top of the longus colli muscle, where you could either come laterally to medially or come medial to laterally through the thyroid. And as I look at the thyroid here with the trachea behind it, I don't see any major blood vessels, but the superior and inferior thyroid artery may come into view as I raise and lower my probe trying to find it. Color mode. So here's the vasculature, and I'm searching for the thyroid vasculature. Here there is some blood more medial to the thyroid, some blood flow. And there we go. We're seeing a blood vessel inside the thyroid at the top. This is probably the superior thyroid artery. So this would be an ideal location to do this stellate ganglion block if we were to go transthyroid. I normally use a 25 gauge 1.5 inch needle. It's usually long enough to get to the posterior border of the carotid artery, beyond that, anterior to the longus colli muscle, B mode. And the longus colli muscle is here lying on top of the cervical transverse process at the bottom of the screen. Okay, here I believe I found the C7 nerve root because there's no real anterior tubercle to it. I'm going to identify the nerve in the center and make sure it's not a blood vessel. Color mode. Okay, it's not, but there is a blood vessel above it, so caution. I am a little low. I'm just going to scan up superior. That's the vertebral artery. And it's going to come posterior as I ascend and disappear into the bony canal, which we may be able to see it. There we go. Okay, so at the level of C6, the vertebral artery goes posterior into the foramen as it descends. So from posterior approach now, I can identify the cervical facet joints. They look like shingles on a house, and they're identified as the gaps in the bone. Years ago, before I started doing erector spinae plane blocks, I was performing what I called cervical facet plane blocks, which were basically the same thing. Landing the needle on the bone underneath the musculature and letting the local anesthetic diffuse superiorly and inferiorly along this to alleviate neck pain, cervicalgia, facet arthropathy, and it actually worked quite well. Now I typically do not do cervical facet injections unless I'm injecting them with PRP. What I typically will do is a lidocaine or bupivacaine medial branch block and use that for diagnostic purposes prior to PRP injection or radiofrequency ablation or peripheral neuromodulation.
Okay, here's the vertebral artery again. So with the selective nerve root blocks, I do like to do them sitting. A lot of people will never do that. I have a good sense of who's going to vagal, who's not, and I'm prepared for the vagal, but I actually never seen it after hundreds of these blocks. I've seen it with the cervical facets, not with the selective nerve root block. So you could have the patient lie on their back as well, supine with their head turned to the side, and you look for the blood vessel, the anatomy. Once again, C4 nerve root at the bifurcation is C3-4 level. You just scan for those anterior posterior tubercles where you have a smaller anterior tubercle. You're probably at the nerve location. And here we're going to point it out, the nerve. There it is. And that's the tubercle behind it. Okay. So as you can see, ultrasound really offers you a big advantage when it comes to actually seeing the nerve and watching the spread of around the nerve. And you don't even need to use contrast. So it reduces expense as well as risk. C5, 6, 7 nerve root identification. What we mentioned in the video, Chasternag's tubercle. Here the nerves are coming into view. And right there is Chasternag's tubercle. And that's a nerve root. C7, hypoechoic nerve root anterior to the posterior tubercle. And you could see the vertebral artery pulsing anterior to it. In fact, the previous video, we did see the nerve. So Brittany's a patient who suffers from chronic neck pain and headaches. The pain is going down both arms?
Mainly the left.
That's your right.
Right.
Mainly the right side. She's had in the past a combination of brachial plexus blocks, occipital nerve blocks, trigger points, accessory blocks, paravertebral nerve blocks, and it's given her over 70% relief. She's way better than she was a month ago when I believe I first met her. And now she wants just a repeat of the same therapy to keep at it and prevent the pain from getting worse again. Since she's had these injections, she's been able to function better at work, etc., correct? And do more, your activities of daily living are easier?
Yeah.
Okay.
Yep.
Very good. So we'll start. The pain goes down the right arm to her pinky.
Yeah. And then it'll go to each finger.
Does it go to the thumb?
No.
Okay, so it's basically radiating more towards C7. So we're going to first find the supraclavicular brachial plexus by the subclavian artery. And we're going to trace it back up to her neck to the interscaling brachial plexus right here. Decrease depth, decrease depth, decrease gain. And just a little flick of the wrist, how I move my ultrasound, you see the nerves appear differently. They appear as a stop sign, one on top of, excuse me, a street light, one on top of the other, or the snowman sign. And increased depth, I could trace them back to the foramen. As you see, they're disappearing.
And C6 is entering at the foramen here. You could see the anterior tubercle Chasternags of C6 anterior to the nerve.
Let's make sure there's no blood vessels in the vicinity. Color mode. Okay, it looks like we're free and clear. The vertebral artery is anterior here and well away from where we want to go. B mode. Capture image. No pinch. Anything shoot down your hand, just let me know, okay?
Yeah.
Negative aspiration. Get a little closer to the nerve. That was closer to the medial branch because that travels posteriorly. You may feel something down the arm now. Are you there, all right? Yeah. A little bit at the 12 o'clock position of the nerve to avoid touching it. Still good?
Yeah.
All right, we're right around the nerve. Going down your arm?
No.
Okay, it doesn't have to. But capture image, you see the needle is 12 o'clock of the nerve, and it's also between C7 and C6. C6 is above, C7 is below. Scanning downwards, I see the articular pillar, where I could do a paravertebral block, as well as get into the facet capsule. Right here. This will get the facet joint as well as the medial branch external to the joint, which is a little hard to see, but it's over there. Doing good?
Yep.
Okay. You have pain higher or lower than this point?
A little bit lower.
Okay, right here?
Yeah.
Okay. And here we could see the articular pillar again. A little pinch. A little trigger point here on the way in.
Yep.
Get her trigger points as well. That's right here is an articular pillar, facet capsule, as well as the medial branch. Once again, hard to see, but it's there. Now we're going to do her occipitals. Scanning the spine, can you just look down, please? At C2, the first spinous process is bifid. And we just scan laterally. We see the obliquus capitis inferior muscle, decreased depth, and the semispinalis muscle, and between them lies the occipital nerve. And it may appear as one branch or more than one. This is the greater occipital nerve before it joins the artery. A little pinch. Right there. Capture image. Just go a little closer to it. And just getting in that plane will dissect. The medication will just hydrodissect over towards the nerve, above the needle. Right here, now centered. Are we doing good?
Yeah.
Okay. Here is the sternocleidomastoid muscle. Posterior to it is the region of the superficial cervical plexus. And analgesia of the plexus will get the transverse cervical nerves, a little pinch, as well as the lesser occipital nerve, and give some relief to her for her headache and neck pain as well. Capture image. Pausing a small amount over there. And sometimes you can see the accessory nerve as well, which should be leaving the sternocleidomastoid heading towards the trapezius, and it's quite superficial, and it's 8 centimeters superior to the clavicle. And I would judge it's in this plane right here, a little pinch. Right there. Capture image. There we go. Just a small amount of local there. I think I have one more thing left to do. Are you okay?
Yep.
Have you had enough, or do you want me to
I'm
continue?
okay.
I'm going to do the suprascapular nerve blocks. So I'm scanning over the trapezius and supraspinatus muscle, looking down at the spine of the scapula, focusing in, decreased depth, at the transverse scapular ligament where the suprascapular nerve lies. And I'm going to deposit a little bit of local anesthetic just to give her some relief of the pain that radiates towards the back of her shoulders, a little pinch. Yep, sorry.
Twitch.
Right down
You
above.
may twitch.
I know, it will do that. Just going to go a little bit more shallow because it was close to the artery. And we're perforating the ligament now. And there we go. Nice spread over the nerve. Needle mode. There we go. Right there. I'm injecting onto the suprascapular nerve. You can relax. Are you feeling lightheaded or dizzy or anything?
No, I'm not.
I'd like to say something. Many of my procedures I do sitting up, which is what many practitioners will not do out of fear for vagal. I've almost never had a vagal in this position with these particular injections. Where the vagal reaction has occurred, the syncope or the near syncope, has been mainly with cervical facet injections. And I'm guessing part of that is because in the facet you could have communication with the epidural space, and the patient could feel faint or dizzy. It could still happen with what I'm doing, and I advise caution. I'm not telling everyone to sit patients up because there is a risk of vagal. I've been doing this for 17 years, and I have a sense of who to do this with and who not to do this with. I know her. She's had a good history of receiving injections without feeling faint, as well as the fact that she's on a table where I'm prepared to lie her down if she becomes lightheaded or dizzy or has any signs of bradycardia or hypotension.
Okay, so briefly, we talked about this. Occipital neuralgia forms a headache from impingement of the nerve as it exits through the muscle. From the level of C2, the nerve emerges. That's where we're scanning here to find the nerve above the obliquus capitis inferior muscle. It may have a couple of branches or one branch on the ultrasound. And here it is basically. Here's just a quick video. And we're identifying the muscle layers after we find the bifid spinous process. And it's basically a hyperlucency with a honeycomb shaped in that plane that we're looking at between the two muscle layers. And I usually don't need more than 1 or 2 mLs. You could also go higher up by the occiput, by the occipital artery. There's different ways to do this. For peripheral neuromodulation, I put a nerve stimulator in at this nerve with an out of plane approach, which you need to be very careful with in the neck. So by the way, I did want to mention these videos are filmed at Pain Care Clinics of Ontario, so I wanted to thank them for allowing me to film there with patients. The lesser occipital nerve, here's an image of it going lateral to the greater occipital nerve. And this is a patient who did fantastic with the occipital nerve blocks.
This patient is suffering with a cervical pain that's right over the occipital nerve and the upper cervical regions. His MRI was clean, so I'm assuming he has some sort of myofascial pain syndrome related to a occipital neuralgia. Have you ever had trigger point injections in your neck?
No, never.
No, okay. So we'll do some trigger points with the nerve block just to try to alleviate his symptoms. So I'm going to scan at the level of C2, looking for the occipital nerve. So the spinous process is central over here. I'm going to scan laterally, and you see the planes of the obliquus capitis inferior muscle and the semispinalis muscle right here. I can angle my probe a little bit to try to get the ideal location. And then I'm going to target the nerve in that plane. And sometimes it doesn't look like just one nerve. It could appear as multiple nerves because they can converge in this area. And you can feel a little pinch it up. I do dissecting between the nerve muscles. Does it feel like I'm in the spot of your pain?
Yeah, you are.
Okay, and it's crossing over between the muscle planes to get the nerve. Now you have some pain in this region, like this, normally?
Yeah.
Okay. Now, in the event that other muscles are involved, I'm going to do some trigger points as well as some paravertebral injection to try to see if I could get the medial branch nerve at this level and denervate any of the tissue. We're not looking, this is not purely a diagnostic block where I'm just doing one thing. I'm just trying to get him out of pain. Little pinch. Capture image. medial
I'm
to
injecting
scalp.
about 0.5 to 1
Over the
ml at each
articular
level.
pillar. Negative aspiration. Capture image.
Okay, the supraorbital block, you could see the nerve with an ultrasound. However, many times the ultrasound's too big to do an in-plane block, so you could do an out-of-plane block with it. Accessory nerve, I do not commonly block this nerve. However, just a brief blurb about it. It really comes, it's small, it exits the jugular frame with the internal jugular vein, common carotid artery, and vagus, crosses the carotid triangle of the neck before traversing through or beneath the sternocleidomastoid muscle. It's not always so easily visualized, and it changes its location as it descends. Here's an image of it. It's about 2 millimeters in diameter, and it lies 1 centimeter superior to the greater auricular nerve at the posterior border of the sternocleidomastoid muscle. Paravertebral blocks, they're quite useful because the medial branch nerves over here, and you can get the facet joints. So whether it's actual true facet arthropathy or a muscle spasm, myofascial issue, it really
So this is a
works well.
patient who presents with a cervical radiculopathy. He also has axial symptoms as well. His CAT scan shows C5, 6, C6, 7 facet arthropathy, as well as foraminal stenosis, and he presents with some numbness and pain down his left arm. The pain passes from his neck through his shoulder. He's had a paravertebral nerve block by his pain physician, which has not given him relief, and he's here today for treatment. To avoid epidural steroid injection and the risk of that, we're performing ultrasound-guided interventions along the paravertebral space, the nerves as they exit the spine. I'm using a mixture of lidocaine and dexamethasone for those blocks. So first I'm going to scan his neck. I'm finding the supraclavicular brachial plexus, which I trace up the spine to the extraforaminal space. And we're tracing the nerves as they go back into the frame. And the nerves are hypoechoic, and they're disappearing. That right there is a posterior tubercle, and here is the articular pillar of the spine. Moving forward, I'm going to put the Doppler on to see if there's any blood vessels. Okay, so there's no blood vessels in our way here. The hypoechoic circles are nerves. And there's a blood vessel right next to one of the nerves, which we'll try to avoid. Here are the nerves once again. C5, 6 is stenotic, and he has impingement of C6 as well as C7, which is centered right here. And I'm going to deposit a little bit of local anesthetic with dexamethasone in the vicinity, a low pinch, okay? Sorry. Anything shoot down your arm, just let me know, okay? Just let me know what you feel. Okay, here's my needle coming near the C6 nerve. Anything shooting down your arm?
No.
You're just feeling in the neck?
No, it was going down my back.
Back down your back, okay.
Yeah.
Okay. I'm taking this needle back. We're going to look at the articular pillars now and target the paravertebral space where the medial branch nerves pass. Does your pain come from below this point or at this point?
At that point.
Okay. And the patient is has a crease in his neck at that point, which is typically where the most movement occurs, and that's where he's complaining of pain. Little pinch right here. Sorry.
It's okay.
Okay, depositing the local on the articular pillar. And go one level down. And pinch again. I'm also depositing some in the trigger points in his neck. Superficial. Sorry. Okay, so I'm going to do two more things and then we're done, okay?
Okay.
Okay, well, first I'll do the accessory. What we see here is sternocleidomastoid, the big muscle here, and going posterior to it, we'll see the region of the superficial cervical plexus at the tail of the muscle. I'm going to deposit a little bit of local there for his neck pain, pinch. And come posterior, looking for the plane of the accessory nerve, which is between the sternocleidomastoid and the trapezius muscle. The nerve heads towards the trapezius after it leaves the jugular foramen. Little pinch. Okay, I think we're done.
So I know this is quite repetitive that we're doing similar blocks over, but it's you're not going to learn this with just a quick video. So that's why there's multiple videos of similar nerve blocks, and the anatomy is different from patient to patient. Third occipital nerve, medial branches and facets. Here we talked about the facets earlier. Here's just another illustration. They appear like shingles. You could do the medial branch blocks prior to RFA, PRP, PNS. The medial branch nerves, from C4 to 8, they arise from the dorsal rami of the respective spinal nerves. Each medial branch curves medially and posterior around the waist of the articular pillar, under the tendinous slips of the semispinalis capitis. Most of the cervical dorsal rami give off one medial branch. However, the higher the vertebral level of the dorsal rami is, the higher the chance of it giving off two medial branch nerves, namely the superficial and deep medial branches. Here's a beautiful image of a medial branch nerve with an oblique approach. Hard to do in plane because of just the nature of the probe and the neck, but what you could do is an out-of-plane block cautiously. This is also for experienced docs because you could easily wind up in a blood vessel or worse in the spine if you're not careful. But as you could really see here, the nerve is right hugging the waist of the articular pillar and underneath the musculature. Third occipital nerve, it's a superficial medial branch of the dorsal ramus of the C3 nerve. It innervates the semispinalis capitis, the C2-3 zygapophyseal joint, and the skin in the suboccipital region. Immediately after the origin, the occipital nerve curves around, the third occipital nerve curves around the lateral and posterior aspect of the C2-3 zygapophyseal joint and crosses the joint laterally. So when you scan, you want to find the mastoid process. Go posterior and anterior to identify the inferior articular process of C2, which is shown as a drop-off. The vertebral artery can be pulsating cephalic to it. Move the transducer caudally to identify the C2-3 facet joint, which shows a small hypoechoic cleft, and the third occipital nerve can be seen lying on top of the C2 inferior articular process as shown here.
This is a patient whose pain doctor referred her for a cervical ultrasound guided injection. She had an injection in the past which gave her a lot of relief of her chronic headache as well as neck and arm pain. She had ultrasound guided brachial plexus blocks, auricular temporal and occipital nerve blocks, as well as cervical facet capsule medial branch injections of local anesthetic with dexamethasone. Today I'm going to repeat some of the injections she had previously, as she's markedly improved since her previous injection, and she still continues to have some headaches some days. She's going to receive an auricular temporal nerve block, an occipital nerve block, as well as paravertebral cervical blocks, which include the medial branch as well as the capsule of the facet joint. And she's also going to get trigger point injections of the neck. So I'm going to look for the auricular temporal nerve. This one we did a while ago. Color mode. I'm looking for her auricular temporal nerve. It runs near the temporal artery. Okay, here's the temporal artery, and sometimes you can see the nerve passing over the artery. Okay, I'm just going to infiltrate in that plane because it's a little hard to see that. Okay, a little pinch on, okay. Pinch. So, prep her neck, go back to her neck. We're going to do the cervical paravertebral nerve blocks. Now, she responded at the levels of C3, 4, 5 in the past. So, scan downwards. Here's the highest transverse process would be C2, and going down would be C3 articular pillar. Right there, a little pinch. Getting trigger points on the way in. Needle mode. Right there, my needle's on the articular pillar. And by the joint capsule, as well as some probably going anterior into the foramen. I'm going to move down, another pinch. One level down, another pinch. Okay.
Okay. A lot of the references in this talk were from this wonderful article in Pain Physician from 2021 by Dr. Lee and Dr. Sabova. I had the privilege to edit this article. It was really insightful, and it really, I think, is a great article to check out. And I just wanted to thank everybody for joining my part of it. If you want more information on tutoring or courses, you could scan the QR code. Shelley, I think it's back to you.
Great. Thanks, Dr. Rosenblum. I always learn so much on these videos and watching you scan and inject. All right, we're going to hand things back over to Janae to give us a quick live demo of scanning the occipital nerve. So she's using the L15 scanner.
Great, thanks, Shelley. Yeah, we're using the L15, and I've got my preset set to the nerve pain preset, and we're going to start posteriorly on the patient here, and we're going to look for that C2 bifid spinous process, and we can see it nicely here on our patient here. So we can see that bifid appearance, and then we're going to move laterally from here, and we can see a few bands of muscle come into play. Most superficially, we can see the trapezius muscle, and then just deep to that, we can see the semispinalis capitis muscle. And then deep to that, we see the oblique inferior capitis muscle. And the greater occipital nerve is the one that we're targeting here. And that nerve lies in the band, in the plane between these two muscles. So we can see it nicely here. It looks like a hypoechoic oval-shaped structure right in this area here. We'll decrease our depth a little bit there, bring it into play. We can turn on the color Doppler when we're doing injections. It's nice to know where the vessels are, so you can plan for your trajectory of the muscle to avoid those vessels. And
awesome. I was going to
nice...
say, sorry, Janae, can I interrupt you for a second? We watched
go right
Dr.
ahead.
We watched Dr. Rosenblum use the voice controls quite a bit. Could you demonstrate that?
Yes, yeah, there's two ways that we can activate the voice controls. We can pre-program a button on the scanner itself, or we can select the tools icon on the bottom left-hand side of the screen and select voice control. And we know that the voice control has been activated because on the top right-hand side of the screen here, we can see that little microphone icon, and that shows us that the voice control is activated. So now we can increase depth, decrease depth. We can increase our gain and decrease our gain, all hands free. So that helps a lot during procedures, like the injections that we're doing here, where we have both hands busy.
Great.
All right.
Awesome.
We'll get your
We've
arm
got a
behind your
new,
back there, please.
new feature in the Clarius app called T-mode, and it stands for texture or tissue mode. And so it's great for people that are learning MSK ultrasound and not sure what they're looking at. So this is an educational tool. Janae is not a shoulder scanner, but she is just kind of in the transverse plane over the anterior shoulder in the region of the supraspinatus tendon. She's turned on the T mode here, and she's getting in real time graphical overlays of tissue types. And then if she hits the freeze button, we're actually going to see anatomical labels. So for somebody who's learning this part of the anatomy, we have other models of this as well, but this is a really helpful tool for those people who are just starting out. Great. Thanks, Janae.
Great, thanks. Thank you.
All right. Now, before we open the floor to live questions, and we are going to go over the hour here just a little bit, but I'd like to do just a quick poll. We've got lots of great questions, so please stay on. We'd love to hear everyone continue their journey to bring ultrasound into your practice. So complete this poll and let us know if we can get you some more information, and click on as many as apply. And while you do that, I'll just take a minute to introduce you to the Clarius HD3, the world's only third generation line of portable ultrasound scanners. So Clarius HD3 delivers best-in-class wireless ultrasound for pain management with an easy-to-use app powered by artificial intelligence and connected to the cloud. And our high-definition scanners are specifically designed to effectively visualize MSK structures and guide pain procedures, and they deliver several advantages. Clarius is unrivaled for near field and high resolution imaging in a handheld device. And as you saw today, you get very clear images of nerves, vascular structures, bony anatomy, and your needle for safe ultrasound guided injections. In each scanner delivers image quality of a larger ultrasound system, but at a fraction of the cost. And with artificial intelligence replacing complex knobs and buttons, it's fast and easy to use as your smartphone. As we see, Clarius is wireless, freeing up space with zero footprint for ultra portability in a variety of settings. You'll get free movement with no wires getting in the way and touching your sterile prep area. And with no wires, Clarius is also so much faster to clean, disinfect, or fully encase in a sterile sheath. And included with your wireless scanner is a free app for your iOS or Android devices for unlimited users. And available with our membership or one-time license, Clarius Cloud can manage unlimited exams from anywhere. Your membership also includes in-app classroom videos with experts like Dr. Rosenblum and onboarding with a Clarius clinician to build your skills. Membership also includes dedicated presets, voice controls, which you saw in action today, the FDA-approved MSK AI that automatically identifies, highlights, and measures the thickest section of tendons. And this, along with T-mode, is designed to really accelerate your mastery of ultrasound, especially for new users. So I invite you to complete the poll for additional information. And if you've already done so, we'll get back to you in the coming week. So I would now like to welcome back Dr. Rosenblum to answer your questions. And again, if you have more, use the questions icon in the menu bar to ask your questions for our great clinician. So let's get to these questions here, Dr. Rosenblum. There's quite a few. Let's start at the top here. I was told recently that we should not do bilateral cervical facet joint medial block on the same. Yeah.
Yeah, this kind of goes along to one of the things I was saying earlier, where you wouldn't do bilateral stellates or deep brachial plexus blocks. But if you're going medial branch superficial, if you're not giving large volume, you should not get the phrenic nerve. That's more of the, I mean, yes, you could get dizzy. Well, you could, unilateral patients get vagal, get dizzy, lightheaded, but bilateral, I'd say, yes, it's a higher chance, but if you're giving low volume and you're watching them, I'd be more concerned with a facet bilateral than a medial branch bilateral, or as well as either brachial plexus or selective nerves and phrenic nerve bilateral. sorry, stellate ganglion bilateral. At the end of the day, it's like the board questions. Basically, whatever you do, know how to handle the consequences of what you do. And that's why I gave that whole talk about sitting the patient up, because many people would never do such a thing.
One of our viewers wants to know if you keep a copy of images of ultrasound procedures for medical legal purposes.
100% for billing, absolutely. And I'm even throwing on the Doppler before I do the selective nerve root or the high brachial plexus, and I'm saving the Doppler image to prove that, hey, look, I was looking before I did it. Look before you leap. Want to make sure that there's no blood vessels in the vicinity.
Have you done perineural injection therapy with D5W for these conditions?
I have not done it with D5W. However, there is evidence that it works. So I probably will. We had a shortage getting the stuff a while ago, but I haven't looked recently.
All right. Do you do subscapularis nerve block for complicated shoulder capsulitis that don't respond to classic treatment?
I do mainly suprascapular nerve blocks, not so much subscapularis. But usually suprascapular is enough for, I'm not sure if that's what you're meaning. That's enough for the frozen shoulder.
All right. For the nerve blocks, are you using a normal hypodermic needle or a toy needle?
Every needle you saw in this was either, well, they were all normal hypodermic needles, ranging in length from 1.5 inch to maybe 2 or probably 2 inches. I use 2 needles basically just for epidurals. So many anesthesiologists will use insulated or echogenic block needles. I don't use those because I've been doing this long enough. I don't need them to see my needle, but if you're a beginner, you might want to consider it.
What's a toy needle? I don't know that.
Oh, that's an epidural needle. It's
okay.
It's a blunt tip, and it's shaped in a special way so that you can get into the epidural space without getting into the thecal space and causing a fluid leak.
Got it. Thank you.
Mhm.
What you injected, just local anesthetic or with steroids?
It depends on what I was doing. Sometimes I use dexamethasone mixed with either lidocaine or bupivacaine. The injections, they vary tremendously in this. Many times you don't need steroids to get relief. And if it's a chronic issue, I would definitely recommend trying platelet-rich plasma.
There's a question about how long will the effect usually last?
Anywhere from a few hours to a few years. It really varies.
Wow.
Of people with just lidocaine, I'd say out of all the local anesthetics, lidocaine, despite its short duration compared to bupivacaine, has a better chance at giving long-term relief than bupivacaine. That's just anecdotal. So no reference, no study.
This is a bit of a long one. Are you performing neck procedures without monitoring? Are you doing scanning in both longitudinal and perpendicular for precise position of the needle?
Right. So I often, I don't monitor when I do a lot of the quick low volume injections. We do have the intralipid and all the resuscitative stuff. But when I'm in my usual realm, not filming everything, we often will monitor for brachial plexus. We'll monitor for larger volumes. If I'm giving just 1 ml of local into the neck per spot, I usually don't monitor, but I have a monitor in the room and we check vitals before and after the procedure.
Yeah, and I think if you're regarding the transverse and sagittal planes or long axis, if you're doing an in-plane injection, you don't need to scan in both planes, right? You can see the whole needle, so you know where you are.
Needle and you know exactly where you are and know where the blood vessels are. You should be okay. If a patient says, I don't feel right or just something's off, you right away lie them down, put the monitor on, and I gotta tell you, I've almost never needed to use any sort of drug to get them out of a vagal. If anything, I might have given them glycopyrrolate just as a precaution, but yeah, I mean, stuff could happen, and it's good to have. You have to have the monitor there, but for trigger points, we don't routinely monitor.
Okay. And there's a question about aseptic technique with the probe and the gel without a probe cover.
Yeah, so these probes, and correct me if I'm wrong, they're waterproof. So you could use a ChlorPrep or a Clorox solution to clean them, and they're sterile after that. I'm not, people who aren't doing this often may slide looking for their targets. If you noted in the videos, I clean with chlorhexidine, and my probe, even though it's a sterile gel, it's never I'm never putting gel over my needle entry point. That's something that comes with time. When you're first starting this, use the condom, use every sterile thing you could do. But, at the end of the day, it's like it's still fresh skin with no gel over it. So it should be really the same risk as doing a blood draw or giving a flu vaccine or any other shot. And just prep it with chlorhexidine.
Yeah, another couple of questions about the needles and
by the way, I've only had probably 2 infections from these types of shots. One was I did it in the ICU, and that one I actually did prep with a condom and everything. But it was an ICU patient. And the other was a peripheral nerve stimulator, which wasn't even ultrasound based, and it was done the traditional way with sterile prep and drape in an operating room. So go figure.
What approach is preferred for stellate blocks, medial or lateral?
Great question. I think it varies on the practitioner and it varies from patient to patient. Sometimes I'll do lateral, but 9 out of 10 times I do medial. I find it's a shorter distance. And if the carotid is clean, if the thyroid is clean, you don't see the blood vessels there, you just go straight through it. But you have to have very good coordination to see your needle the whole time, because you could very easily wind up in the carotid, which could be a disaster.
And you don't use local.
Oh, that's a great question. So a lot of us anesthesiologists train to do a skin wheel and then put the needle in. If you're doing a shot with a 25 gauge needle, that's the same gauge as your skin wheel. You are probably going to cause the patient more pain by doing the skin wheel than just sticking it right in. And I know that from personal experience on myself. So.
All right. I love this question. I was impressed by your needle skills with both hands. How did you become so proficient?
My advice is, when you're learning this, become ambidextrous. Just learn to just switch whenever you have to switch sides on the patient. It's going to make your life much easier. It might be a little bit of a learning curve, but learn to use both hands for depending on what side of the body, so you're not twisting over or you're not doing anything awkward.
Is there a maximum amount of injections a person can have for chronic neck pain?
I'm so happy you asked that question. So in the United States, you'll typically get paid for one thing at a time. In other countries, you could do multiple treatments. If you're treating a patient with the neck, shoulders, arms, headaches, that whole thing related to cervical disc herniation, cervicalgia, radiculopathy, if you don't, one epidural could basically terminate all that. Epidurals do work great. I'm not against them. I just think there are less invasive means. And sometimes when you don't do the epidural and you go to the brachial plexus or the exiting nerve root or the paravertebral, you'll need to supplement by doing all those little peripheral injections, which means more needle sticks. But these are low risk needles. And if you see in the image, in the videos, I'm using very low volumes. So you're getting a lot of relief at the different peripheral targets, but you're nowhere near the spinal cord. So it really depends on how comfortable you are and your individual patient. I just try to do what the patient needs, nothing more, nothing less.
Okay. There's a lot of Clarius product questions. I will respond to those separately by email. And Dr. Rosenblum, just kind of to be respectful of yours and everyone else's time here, I think we'll call it, if you can maybe respond to the last couple of questions we can send you by email, that would be great. Yeah. We've reached over the top of the hour. So thanks so much for all of your questions, everyone. You will receive a PDF copy of the slides and a webinar recording in the coming days. So keep an eye on your inbox. And once again, Dr. Rosenblum, thank you so much for sharing all your insights and demonstrations. And a big thank you to all of you for joining us. I hope you have a really great rest of your day and keep scanning.